And we're now getting down to the median nerve at the carpal tunnel, probably the most common exam you're going to be doing. A check for any irritability of the nerve. And when you're doing a Tendon sign, generally start from distal and work proximal. And that's for any Tendon sign, anytime, any condition. Why? Once you've induced irritability in the nerve at any level, you probably will have irritability of that same nerve distal to it. What you'd like to do is identify the Tendon sign at its most distal point and then follow it proximally. Why? Tendon sign was described to identify recovering, regenerating axons. So you want to find the most distal point of recovery and work your way backwards. So if we'd had a previous injury of the median nerve here and it was regenerating distally, we'd want to start out here on the first web space or the index web space and see where we pick up a Tendon sign. And I'm just tapping lightly along the course to see whether there's any irritability. Oftentimes people will have irritability of the median nerve at the wrist. Does that induce, you get any tingling in the fingers at all? And then move all the way on up through the forearm and even up into the cubital region. All right. For carpal tunnel syndrome, you should have intense irritability of the nerve at this level, radiating down generally into the middle finger, sometimes middle and ring, or sometimes all of the fingers in the median nerve distribution. Next, we follow with Phelan's sign. Phelan's sign is simple flexion of the wrist, keeping the elbow straight. Why? If you flex the elbow again, you might get some vascular-induced neuritis of the median nerve. So flex the wrist fully, and I usually would do both wrists at one time. I don't generally ask the patient to do that because, again, in order to do that, you've got to flex your elbows. So I'm going to ask her to keep the elbows straight, flex the wrist fully, and see if that, over the course of a minute, causes paresthesias. A minute's a long time to wait. Generally speaking, a patient will have paresthesias in 15 to 20 seconds if they have carpal tunnel syndrome. Does that cause any tingling? All right. Next, I'm going to do reverse Phelan's test, which is to forcefully hyperextend the wrist and see if that produces paresthesias. Why? Actually, government studies showed that this is a more provocative test for ischemia of the median nerve than a flexion test. So do that, same thing. And I generally don't ask leading questions. I generally say, does this cause anything different? Or just some general question like, does this cause any change in your hands? If you say, does this cause tingling in your middle finger, patient who's volunteering answers will certainly answer yes. All right. If you want to lead someone down the garden path, you might say, does this cause tingling in your little finger? If they answer yes. There aren't too many conditions that will do that. Occasionally, Guillaume's canal entrapment will do that. So those are the big three provocative tests for carpal tunnel syndrome. Durkin's sign is putting pressure directly over the transverse carpal ligament with your thumb. That may induce paresthesias. I haven't, in my practice, found that a very worthwhile exam, but it's in the published literature. Some people feel it's more specific. I find that a Tendon sign is very nonspecific. It's irritability. A Phelan's test is a pretty good indicator that you have compression of the median nerve, particularly when it matches with subjective symptoms of paresthesias, nocturnal paresthesias, and particularly paresthesias with fixed wrist activities. The big three: driving a car, reading a book, using a phone. If someone describes paresthesias in all three of those activities, that to me is fairly pathognomonic for carpal tunnel syndrome, particularly when you've got a positive Phelan's test at 15 seconds. I'm going to follow that up with electrodiagnostic studies, but I'm really honing in on that as my diagnosis. Then again, of course, you do what I showed before about the testing of the thenar muscle strength, opposition strength, and two-point discrimination in the median nerve distribution. I'm going to finish up with some examinations of tendinopathies about the wrist and hand. These are probably the second most common condition we're going to see after nerve compression disorders of the upper extremity. They include trigger fingers, de Quervain's disease, trigger thumb, and wrist extensor tendinopathy. Those are probably our big three. Trigger finger, the most common tendinopathy we see. Patients will complain of catching and locking. Sometimes they'll come in with a partially flexed finger. The pathology is at the A1 pulley, which can be pretty much seen here at the distal palmar crease on the ulnar side and the proximal palmar crease on the radial side. This is right at the level of the MP joint. Of course, as the flexor tendons cross the MP joint, they're kept down by a so-called pulley, which prevents them from bowstringing away from the hand when a patient makes a fist. So what we're going to be doing, since the A1 pulley is the problem, is first applying a little pressure over the A1 pulley. Does that cause any discomfort? I'm then going to ask them, while I've got my thumb there, not applying too much pressure, ask them to go ahead and flex their fingers. Go ahead and make a fist. And then slowly open the hand up. In a patient with trigger finger, go ahead and flex your fist again, all the fingers except the affected one are going to open. So go ahead and open. I'm going to keep this guy down. Yeah, you're going to see that kind of a exam. Right now the finger's locked, and it's probably abetted by my thumb putting pressure on that pulley. If I then give a little forceful pull on it, it unlocks with a snap. All right, that's a trigger finger. Again, there aren't too many conditions that mimic that. I've had patients sent to me with all kinds of diagnoses, including writer's cramp, focal dystonia, dislocated finger, etc., when in fact the pathology is just a trigger finger. So look for that. In patients with inflammatory arthritis, oftentimes you'll see synovitis all the way up and down the finger. Don't be led into thinking this is an isolated trigger finger in someone with inflammatory arthritis. It's probably more likely synovitis of the entire flexor mechanism. So be careful of that and be sure that you examine all the way out to the fingertip. Next most common condition, de Quervain's disease. Not de Quervain's tendonitis, de Quervain's disease. Sounds horrible to a patient to think they have a disease, but that's what it was called originally, or washerwoman sprain. Not too many of my patients like being told that they have washerwoman sprain, but that's how it was described in 1898. What you're going to do is look for problems around the first dorsal compartment. Of course, you have two main tendons, the abductor pollicis longus inserting here at the base of the thumb metacarpal, and the extensor brevis running just dorsal to that, coming out to the base of the thumb proximal phalanx at the MP joint. They're running through a very tight first dorsal compartment. Frequently, the abductor pollicis will have 2 or 3 slips. Sometimes the extensor brevis will have a separate subcompartment in it. Whatever the case, they get inflamed, they get tight, they get entrapped. The outer sheath actually thickens, and then you get a friction component which adds to the problem and sort of cycles on itself. The way we're going to test that is to ask the patient to flex their thumb and put their fingers around. You can see the tendons of the first dorsal compartment really standing out here, and then you're going to ask her to relax the muscles of her forearm as you take them from radial to ulnar deviation. What I'm doing here is stressing and pulling those tendons through a very tight stenotic canal, and in a positive situation you won't get much past here before the patient complains of severe pain and actually withdraws. That would be a positive Finkelstein's test. It is virtually pathognomonic for first dorsal entrapment. Confirm that with local tenderness over the first dorsal. The so-called wet leather sign has been described to indicate some crepitus that occurs along the tendons as you draw them through that canal. I don't find that very useful because it just doesn't exist all that often. Be sure to differentiate this from basal joint arthritis, which is a confounding diagnosis in many cases. Same patient group oftentimes, a sort of a 40 to 50-year-old, more common in women than men, patient who has pain in this area. Frequently, the most frequent demographic for de Quervain's is the 30-year-old female first pregnancy. That doesn't mean it can't exist in a 70-year-old male. It's just the most common. So if you have a 30-year-old woman who's pregnant in the 3rd trimester complaining of pain on the radial side of the wrist, you can pretty much hone in on that diagnosis, but don't forget the basal joint. So a quick stress test of the basal joint, see if it subluxates out of its fossa and see whether that causes any pain. Tenderness directly over the joint itself, any tenderness there? And then tenderness at the STT joint, scaphoid trapezial trapezoid joint, tenderness there. And then finally what I ask patients to do is lift their thumb metacarpal phalangeal joint against resistance. Go ahead and push up with their thumb. What I'm doing here is actually forcing all that extensor power across the basal joint. In a patient that has an irritated, inflamed, subluxated basal joint, that'll be intensely painful. So you want to check for that as well. And that will not irritate a first dorsal compartment. So you can try to discriminate those two conditions. Lastly, in terms of tendinopathy, and less likely, less common, are extensor tendinitis about the wrist. What you're going to do first is ask the patient to go ahead and extend their wrist. Go ahead. And you can see the wrist extensor tendons highlighted there, standing out. Second dorsal compartment tendinitis is most common, sometimes called intersection syndrome, but really this is second dorsal compartment tendinitis. And then extend the fingers against resistance and see whether either of those maneuvers causes tendinopathy. Moving on to tendinopathies about the wrist, the most common, flexor carpi radialis tendinitis and flexor carpi ulnaris tendinitis. Flexor carpi radialis tendinitis has to be discriminated from de Quervain's tendinopathy, scaphoid fractures, basal joint arthritis. It comes right across the scaphoid tubercle, and that's where it gets irritated. Right as it passes across the tubercle and down to insert on the index metacarpal base, it can get entrapped in a very tight sheath. It can get fibrotic. If you place tenderness just to the ulnar side of the tubercle, patient with tendinopathy will complain and maybe withdraw. You can then ask them to bend their wrist against resistance, this time resisting their index metacarpal. You can see the Flexor carpi radialis standing out. Go ahead and pull down against me. Standing out. In a patient with FCR tendinitis, they're not going to be able to do that. The way to confirm that is a diagnostic and therapeutic injection of lidocaine, probably with a water-soluble corticosteroid injection like Celestone or dexamethasone. Please don't use depomedrol or Kenalog in the subcutaneous regions for de Quervain's disease, FCR tendinitis, or any of the wrist extensor tendons. It will frequently cause subcutaneous atrophy, depigmentation, and a lot of complaints. So if you stay with a water-soluble dexamethasone, Celestone, you're going to have happier patients, probably with just as good results. Flexor carpi ulnaris, go ahead and flex your wrist to bring it out. You can see the flexor carpi ulnaris tendon here. Inserts on the pisiform and then distally on the fascia of the hypothenar muscles. It can be a site of so-called calcific tendinopathy. The weekend warrior, Wall Street executive, comes home, chops 3 cords of wood over the weekend, comes in your office Monday, he's got bright red cellulitis, what appears to be cellulitis and exquisite tenderness about the pisiform. Think about the diagnosis of calcific tendinitis. It's not to exclude cellulitis, but the story's not right for cellulitis. Think about calcific tendinitis. It can mimic infection. It's exquisitely painful. A resisted wrist flexion would be painful. Sometimes on x-ray you see a little fleck of calcium. It generally takes 7 or 8 days for that fleck of calcium to manifest itself, but think about that with that kind of story. And then turn the wrist over. Extensor carpi ulnaris tendinopathy. Resist me here, Joy. That's it. You can see again the extensor carpi ulnaris tendon standing out. Occasionally, through a very tight stenotic sheath here, patient will complain of pain with that maneuver. It can mimic all kinds of conditions about the radial ulnar joint, radial ulnar instability, triangular fibrocartilage complex tears, lunotriquetral instability. The list is endless. But that maneuver will help you sort out extensor carpi ulnaris tendinopathy versus some of those other conditions. Sometimes you'll see when a patient supinates and pronates the wrist, you'll see that extensor tendon flipping over the ulnar styloid. Go ahead, and I keep my fingers over that. It's normal for it to move a little bit, and it has to, in fact, slide over that styloid. But if it pops over, subluxate over, or causes pain, that would be indicative of a unstable extensor carpi ulnaris tendon, which on occasion has to be fixed. Moving on now to instabilities of the wrist. This is a terribly important facet of the wrist examination, particularly when someone complains about pain following a fall on the outstretched wrist, following a forceful backhand or forehand tennis shot, maybe a fall when skiing or snowboarding. Think about problems, both fractures and sprains of ligaments about the wrist. Fracture of the scaphoid would be the most common. Of course, the hallmark of scaphoid fracture is snuff box tenderness. Keep in mind that only 15% of suspected fractures of the scaphoid actually are fractured. But look right here. Bring your thumb up if you would, Joy. Look right there. Bounded by the extensor pollicis longus and the first dorsal compartment is a depression, so-called the snuff box. That is the mid-waist of the scaphoid. Tenderness over the scaphoid is presumed to be a scaphoid fracture in the context of a hyperextension wrist injury until proven otherwise. You can help sort that out by seeing if their tubercle's tender. The combination of snuff box tenderness, tubercle tenderness, and then axial grind. I'm actually pushing down on the metacarpal. The combination of pain with those 3 maneuvers is fairly indicative. It's about 90+% specific for a scaphoid fracture in the context of the right story. So having ruled out a scaphoid fracture, you next want to look at the scapholunate interosseous ligament, which is right here, the so-called soft spot of the wrist, just distal to Lister's tubercle. If I'm putting pressure over that in an uninjured patient, it won't be painful. Painful? In a patient who's fallen on the wrist and injured that ligament, that's not only going to be painful, you're going to probably see some swelling over there. I'm then going to do what's called the scaphoid shift maneuver. I'm just going to slide over here, and I'm going to examine the wrist, and I'm going to bring the wrist through a flexion extension maneuver and see if I feel any abnormal motion of the scaphoid. With the wrist and the forearm completely relaxed, I'm going to put pressure on the scaphoid. What I'm doing is trying to force it out of the scaphoid fossa. At the same time, I'm ulnar to radial deviating the wrist. So I'm taking it from ulnar to radial deviation and seeing if I feel anything happening in the scaphoid and then letting go of my pressure. In a patient with an unstable scaphoid, I will have forced the scaphoid out of the fossa and then let it return. And you can actually feel a clunk. You have to get used to that exam because with patients, and again more so in women than men, you get a fair degree of ligamentous laxity which allows the carpal bones to move around normally. You always want to check against the opposite side, and don't presume someone has scapholunate instability until you've confirmed that with a diagnostic imaging study such as MRI scan, arthrogram, which is not used all that often anymore, or arthroscopy itself. Finally, the last instability exam is something called mid-carpal instability, and you can see in someone with a lax wrist, relax your wrist, that I can actually move the wrist up and down, and they'll appreciate a kind of a clunking maneuver, and you can actually see a little depression in the skin here. If I combine that palmar translation of the wrist with a radial to ulnar maneuver, you can actually see a clunk occur. What's actually happening is the lunate is going from a fully flexed posture to a fully extended posture, and it's clicking back into position. This will normally happen in someone who has, in athletes, in women, someone who has a lot of laxity of their wrist as a normal maneuver. In someone who has fallen, injured this side of their wrist, they may have, in fact, a lunotriquetral ligament injury, which is allowing the bones to move abnormally. In the face of an asymmetric exam that causes pain, start thinking about a lunotriquetral ligament injury.